Like a conveyor belt to process food, our gastrointestinal tract transforms what we eat into the elements we need to survive. Problems along the GI tract tonight, on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We are what we eat, or so the saying goes, but how our bodies convert our dinners into the nutrients we need is amazing. It's a 6 to 7 yard long system that's packed into our body. The digestive tract can have its problems too. For example, ulcerative colitis is an inflammatory bowel disease that affects about 700,000 Americans. We'll be answering your questions about this and everything GI tonight. First, let's take a look at this week's Prairie Doc quiz question. Pick the best answer now. Best answer. Screening for colorectal cancer, A, should begin at the age of 40. B, at bare minimum, should involve checking the stool for blood yearly after the age of 50. Or C, involves having a colonoscopy every 5 years starting at the age of 55. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But we'll answer your medical questions about GI tract all night long as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Christina Hill Jensen of Vera Medical Group Gastroenterology and Dr. Tim Ridgway, Dean of Faculty Affairs, USD Sanford School of Medicine. Welcome. Thank you for being on the show once again. We're kind of going over it. You've been on the show like 5 times,
This
and you've
is
been
my
on
fifth, yes.
Yeah, and you've been on it like 8 or
Probably
something.
7 or 8, I think, somewhere close to that.
So, well, if you do this kind of a television show long enough and you have good friends, you kind of include them as much as you can. So, thank you for doing this.
Thanks for having us back.
Yeah.
So, Christina, where are you from, and what got you into medicine? And tell us that little story.
Sure. I'm from Brookings, South Dakota originally. My mother was a nurse, and I loved being in the hospital. And so from a very young age, I knew I wanted to be a physician. So I went to medical school at the University of South Dakota, became an internist, did internal medicine at Tulane University, and then I really enjoyed the GI tract. I liked the idea of doing procedures, as well as a lot of thinking, and then seeing patients in clinic in the afternoon. For me, it was a perfect mix. So I started my fellowship at Tulane, University of New Orleans, and then finished up at the University of Iowa.
Interrupted by a hurricane.
Oh, yeah, and Hurricane Katrina sent me north. Yes.
Kind of blew you north.
It did. And I've been here in Sioux Falls for 10 years, practicing at Avera. Mm-hmm.
Yes, and you have how many children?
I have one son who is 7.5. Yeah.
So, Tim, let's tell us a little bit about your experience.
Well, I'm from a little town called Ravinia, South Dakota. I'd love to know how many of our viewers have heard of that. I grew up on a farm. I was going to be a veterinarian. I loved going out and dealing with the animals till I got kicked one too many times and thought, well, maybe medicine will be my calling.
They still kick you, but not quite as hard.
Exactly. So I too went to the University of South Dakota, like Christy, and then I did my internal medicine and my fellowship in gastroenterology at the Mayo Clinic. Came back to South Dakota. I've been here 26 years now. But my path took a little bit different course. I still love seeing patients, but I also love education. And 10 years ago, the medical school came calling, and so I have an opportunity to try to mold the next generation of students, which is a wonderful thing. And I still practice gastroenterology at the VA, which has been a great thing for me to give back to our veterans.
So it's a joy to have this experience, this gastroenterology experience, but you have a different kind of experience, both of you. Christy, tell us a little bit about what your common day is all about.
Sure. So my mornings are spent doing procedures. So that long flexible tube, a light and camera on the end of it, and I look inside. So I go and I spend time doing upper endoscopy, looking at the esophagus, stomach, and then spend a lot of time in the colon as well, screening for colon cancer. In the afternoon, I see patients in clinic. My area of interest, I really enjoy working with patients who have celiac disease as well as inflammatory bowel disease, so Crohn's disease and ulcerative colitis as well.
So we're going to talk about celiac in a minute,
Sure.
but I want to talk about your day. Typically, you have 2 half days or 2 days.
It is not boring at all, Rick. You know, I will, like I said, I'm director of the endoscopy unit at the VA hospital. I'm what we call an interventional endoscopist. So I basically will take the more complex endoscopic procedures that need to be done at the VA, and I spend 3 half days a week doing that. But then at the medical school, as you said, I'm Dean of Faculty Affairs, meaning I oversee our wonderful faculty, all of who have been on your show and done a wonderful job. That is just a really fun job. But I also go down to Vermilion and I get our students bright-eyed and fresh, bushy-tailed, and we teach by organ system, and so I help give them the clinical aspects of gastroenterology in the GI tract. Keeps me honest, makes me good at what I do because I'd better know the answers to their questions.
Yes. So one of the things that we talked about earlier before the camera was about people who have trouble swallowing. Food gets caught in their throat. Explain to us what the word dysphagia means.
Dysphagia is something that I think many people don't even realize is an abnormality, and it is. But the classic story is people will come in and they'll say, Doc, I'm eating food and it gets stuck. And I'll have to drink water, I have to posture myself, and eventually it goes through, but every now and then it gets stuck, and then they have to come to us where we have to go and remove it. Commonly, that is not a normal symptom, and it has to be investigated. One of the most common causes is a benign stricture or a scarring of the esophagus, and that's due to acid reflux. We've talked about acid reflux on this show, and I think our viewers probably understand it pretty well by now. But what happens is this acid, as it regurgitates to the esophagus will try to heal, just like if we cut our hand.
Right.
And it scars. And so the esophagus will narrow down, and if you eat a solid piece, it's usually something solid. Dry bread, chicken, meats.
Dry chicken.
Dry
chicken
chicken
breast.
is a classic one.
Yeah.
Or on Thanksgiving, guaranteed, Christy, we're going to see somebody come in.
I did
Yes.
this year.
Oh, when you're on call Thanksgiving, it happens. And it can be serious because if you can't get anything through, some people can aspirate or their saliva will not be handled and it will go into the lungs and cause a serious problem. So if you have that, definitely should be investigated.
Well, the worry that I always have, and I remember hearing this, is dysphagia is cancer until proven otherwise. Now, do you obviously think that that's a consideration because you recommended to have it followed up?
Absolutely. That usually with that requires an endoscopy because not only can we diagnose the problem, but we can actually stretch the esophagus if there's a benign stricture. Now, cancer can be a cause of this. Usually that is, someone will come in and tell us it's been within a year and it's getting worse. That scares us. And that's cancer until proven otherwise. Other people will come in and say, you know, Doc, I've had this for about 6 years. It's off and on. It's starting to get worse. That still needs to be investigated, but less likely to be cancer and more of a benign condition.
Right.
And then there's this other category too, the youngsters, I call them.
Yes.
The young 24-year-old man who says, you know, I have a little bit of allergies and occasionally I just feel that piece of food getting stuck. And that's a category called eosinophilic esophagitis.
Oh, wow,
And
that's a new diagnosis.
Yeah, and so we can see this almost allergic-like reaction in the esophagus, and it's a really unique subset in our youngsters. So
Our youngsters
young
like
Young males is the
20-year-olds.
real freedom.
20-year-olds, 30-year-olds, 40-year-olds.
Yes.
And why in the heck do they get eosinophilic esophagitis?
So we're still trying to figure it out, but there really is this influx of these inflammatory cells. In some people, it's actually due to certain food items. I have a patient who cannot eat corn, for instance. Others,
So it's
we
a
don't
food
know.
allergy, maybe.
Right, possibly. And so
Parasites.
Nope, no parasite. Nope, no parasite yet. But we're still trying to figure out what the immune system is doing to cause this reaction, all these inflammatory cells. And this also can cause considerable
same-
scarring
Oh,
as
yes.
well. And it can be really
that's it.
challenging.
And then they'll have this dysphagia again.
Exactly.
So the take home is get it investigated because
Young or
it's
old.
not normal.
You can treat it too, can't you?
It's very treatable.
Yeah, exactly.
Tell us a little bit about, well, I want one more comment. I want us to talk about cancer of the esophagus because it really is hard to catch early. The clue is, right, dysphagia. How common is it? Not that common, but it does occur. What is it, the person who has constant reflux that gets cancer?
Well, not necessarily, and I think that, those patients are the ones that we're following and saying, well, maybe we should take a look. The ones I worry about are the ones who have silent reflux, and those are the ones who will have Barrett's esophagus or a precancerous condition, and they won't know because they don't have the typical, eat a big spicy meal and have that heartburn or reflux coming up. So we can see individuals who don't really have typical heartburn symptoms who can develop esophageal cancer as well.
So my concern is, of course, anytime that's not working and you're above the age of
Well, it's 5-0.
5-0 is the magic.
5-0 is a
things.
bad sign for cancer. I wanted to make a point about having you guys give us a call. Think about it. The questions are important to us. We need your questions. This is your show, gastrointestinal system. There's a million questions out there. Having most any disease can bring about some depression, but how you deal emotionally with your disease can affect your prognosis.
My mother was Helen Wood, and she was a high school teacher in Stuttgart, Arkansas. She taught the business courses. And in the early 60s, she developed ovarian cysts that would burst and she would pass out. So they decided to take out her female organs, had a hysterectomy. And in the course of doing that, they found some traces of cancer in the fallopian tubes. So they decided they should do something right away with that. And so she had chemo and radiation, and the radiation gave her some burning of the skin and so forth, but it put it off into remission for a number of years. But then it developed into colon cancer. She found a colon cancer just poking around at her stomach, and she went in to the local doctor, and he decided to do surgery on that, and she was put on chemo and did really well on chemo. She never lost her hair, and she had a real positive attitude toward that, and she was teaching. They had done an ileostomy the first time. That's something on the small intestine up high, and then they restored it. I think it was several years later, she developed another tumor, slow-growing tumors, and she had a colostomy at that point, and she stayed on chemo for a little while. It took a while to take care of it, but she was responding really, really well to chemo and so forth. She went through that situation for 14 years, from 62 to 76. And then she finally passed away. It finally got into her entire system. It metastasized. But she had a really good outlook on having the disease, and she lived with the disease, and she would really encourage her friends at that time. One of the teachers put her house coat on and didn't come out of it, and Mother would say, "Get out of your house coat and go do something." Mother was substitute teaching even though she had a colostomy. She just went through it and did everything positively, and I think there is a brain-body connection. And not to say that those people that die of cancer suddenly, she probably caught it early, and then the different medications, took over and kept her in remission for a number of years.
Thank you for that interview. The value of a positive attitude, wow. I would say again to you that this is your show. Your questions are key to our show discussion. Call in your questions to 1-888 376-6225, or send us an email to ask@prairiedoc.org. And we do have some questions. Any comment about her story about her mom?
I love the attitude part, because I think all of us have seen patients who come into things with such a tremendous attitude and how they do well. But then you'll get to a point where they realize that you know, the quality of life isn't there. And it's amazing how they just are very peaceful and say, you know what, enough is enough. And we will see them die within a short period of time. I think that mind-brain, connection is huge.
Powerful.
Yeah,
Absolutely.
very much.
What kind of a diet should you follow if you have diverticulitis?
Well, we used to say, or some used to say, avoid popcorn, nuts, and
Kernels,
seeds.
and seeds.
Right. But actually, they've looked and done what's called a meta-analysis and reviewed all these studies and looked at patients, a larger group of patients, I think greater than 10,000, and this was about 4 to 5 years ago, and found out that it doesn't matter if you eat popcorn, nuts, or seeds. You need to eat a healthy diet, a high-fiber diet. You need to stay active. You need to stay trim. Obese patients have a higher risk of diverticulitis.
I love that question. I love that question because to this day, we will see patients come in that we're told they need to avoid, and think about it, the foods with seeds, tomatoes, vegetables, they're good for you. And we were ignoring those and staying away from them for years for no good reason.
Doing the wrong thing.
Doing the
I
wrong
mean, we
thing.
thought we were right.
Well, sure we
It's
did.
the story of medicine right across the board,
Right,
isn't it? We
right.
change our minds about things when we have science that supports it. You know, we need more fiber, not less. And so that's my answer too. I like ground flaxseed for people
Yes.
as a good source of fiber,
absolutely.
and it has fish oil equivalent with it, so that does heart good and helps your bowels work regularly, and that's all those good things.
Yes.
Has GRD, has Barrett's. Is there something to be doing at home to help prevent control or the growth? This is a 90-year-old man who has GRD and has Barrett's. So I'm thinking he has GERD,
Yes.
has GERD.
Yes.
So explain what gastroesophageal reflux disease is.
Well, what it is, and contrary to popular belief, it's not an overproduction of acid. It's simply that when we eat, the stomach stimulates a huge amount of acid production. And ordinarily, there's a sphincter muscle, a valve, that will close and allow the stomach to churn acid and break down food into small particles. But with acid reflux, that valve is a little deficient. It's relaxed, and so the acid, instead of staying in the stomach, will regurgitate up into the esophagus where it doesn't belong. In certain individuals, over many years, that acid will change the lining of the esophagus to actually look like the lining of the stomach. That is
You
what
would think that that would be protective, right?
you would, and you know, it's interesting because many of them, their heartburn will go away.
Because they now have lining of the stomach kind of lining.
And Christy was talking about these silent, and those are the people you worry about. Now, who's at risk for it? Males. Sorry, guys, but males.
There it is.
And we're learning now overweight, obesity.
We'll have more of this Barrett's esophagus.
Yes. Now, what can you do if you have Barrett's to prevent? And the bottom line is, if you can maintain and reduce the acid reflux as much as possible with medications, and then we do surveillance of the esophagus every so often to look for that small percentage. We're actually learning that the risk of cancer is not as high as we thought it once was.
It's like how much? 1% per year?
For short segment Barrett's, less than 3 centimeters, 0.5% per year.
Which is very low.
Very, very low.
And the majority is short segment
Exactly.
Barrett's. If it's way up, then it's a lot bigger of a
It can
deal.
go up to 6% per year. But again, just like I tell my patients who have a colon polyp, you need to get into that surveillance program. So we go, we look, we biopsy, sample.
Make sure that they're safe.
Because if you find anything early with cancer, you can actually remove it through the telescope.
Rather
And
than
it can
having
be
to go to
curative.
esophageal cancer surgery.
Surgery.
He's 90 years of age.
Exactly. I'm glad you brought that up.
So we think he may have presbyesophagus, right? What is that? What is presbyesophagus?
So abnormal contractions of the esophagus with presbyesophagus.
So it's just kind of, instead of this nice toothpaste tube, it's just kind of chaotic.
Doing a
Does that give you symptoms?
Sure, people can have chest pain, more difficulty with swallowing as well.
Okay, all right. And this guy's 90. Very interesting. Good for him. Nice Thanks for watching. I'm a 77-year-old female from Sioux Falls and suffering from constant constipation. Is it safe for me to take milk of magnesia every night? Tim.
You know, there was a myth out there that was saying you couldn't take stimulant laxatives for a long period of time because it would actually hurt your colon and make it even more prone to constipation because you'd less contraction. That is not the case. It depends how much. Now, obviously, we don't want our patients taking a half a bottle of milk of magnesia on a given day, because then you can get, it has magnesium in it and you can get magnesium toxicity. But a small amount of milk of magnesia, if it is helping the colon, really should be relatively safe. Now again, I would encourage the viewer that high fiber diet, very important. I always tell people drink plenty of water. In our Western culture, we just don't drink enough fluids, and that can have an impact as well. But I don't know what your feeling is, Christy, but on milk of magnesia, if it works and if it's used in moderation, I'm fine with it.
Yeah.
Yeah. Well, and you know, some patients can't really choke it down over time either. I love patients, I would love them to take Miralax. I think that's a very safe laxative, and the person can titrate that dose up and down very safely as well. It's over the counter. So there are a lot of other options, but I agree with Tim. Yeah, it's fine.
The Miralax is the one that the medical letter definitely says this is the first thing. Miralax, Miralax, Miralax.
It's a wonderful thing. It's kind of like the stuff we give for colonoscopy, only a smaller amount, and it just lubricates. It doesn't get absorbed. It doesn't stimulate. It just lubricates the large intestine.
It doesn't leave a mess, and it works, you know, for a guy who's been having a little problem with this, my radiation, I get a little constipation, and Miralax is the answer, and stool softener.
Yeah. I think with all of us, Miralax is the go-to at this point in time.
Right. How about this question? My husband has Parkinson's and COPD. Those are not those are not GI tract diseases. But at the end of the meal, he'll start to choke on mucus. Where does the mucus come from after he eats a big meal?
Well, with Parkinson's disease, it's a movement disorder, right? And it affects the neurologic system. And part of that can affect the coordination of the esophagus, which we've talked about earlier. And so we will see swallowing problems. Usually patients will tell us it's not just solids, it's liquids and solids. The mucus is like when we eat, there's a stimulation of saliva, number one, that helps to break down food, break down proteins, and then we swallow, and then of course you get the increased acid secretion. So I think the mucus that the viewer is talking about is the combination of that increased salivary input with the food that is unable to be cleared effectively, and so they're feeling like they're choking on this material.
Yeah. Or there could be some aspiration and it's irritating the upper airway, and there's mucus there too.
Yes. Could be some of it could be coming from the upper respiratory.
You know, there were some questions on my radio show yesterday that was triggered, and one question was, if I take pantoprazole, which is like Prilosec, it's a proton pump inhibitor. Can I get off of it after a year? Been on it for a year. You need to taper it, and can I get off of it?
Sure. So you can definitely try to have kind of a step-down therapy. I think there's been a lot of press lately about these medications, the class of medications called proton pump inhibitors, where they've made the 530 news, and you see, oh no, these medicines might be related to heart disease, they might be related to kidney disease, and one of the last ones was Alzheimer's even. So there's a lot of fear about these medications and possible long-term consequences. So we don't have a blanket statement saying take everyone off. However, if your reflux symptoms are controlled, you're doing well, you can definitely try to step down. It can be challenging, however, because when you are trying to come off of these medications, you get this kind of rebound effect where there's even more acid production. So I tell my patients, use the good old-fashioned medication, ranitidine, Zantac, while you're coming off. And if you only have that intermittent reflux a few times per week, stick with Zantac. It's cheap, it's very safe as well.
I like the idea of tapering it, although I've heard the taper sometimes takes 3 months if you're going to taper off a pantoprazole or a omeprazole or any of those.
But I think the key point, and Christy just hit it on the head, these medications are very good for individuals that need them. But many times they may be given this medication and it's never addressed again, and patients
just
think they
stay
need
on it.
So
And they can't get off of it because they have
exactly.
rebound.
So it behooves the physician that prescribes it to monitor these people, because many of them don't need it long term, others do. And you just have to separate those two, because I still say if I have to take a medicine long term, if I need it, it's one of the safer ones you can take.
Right, right. I think all of this about the dangers is really blown up. The 5 o'clock
Yes,
news stories.
yes.
But, I mean, C. difficile overgrowth is another thing that
Yes.
we're
Yes,
finding. There's an
absolutely.
association, but how much of association when you've got a drug that really works? But realize that if you're tapering it, you got to taper it over a long period of time, gradually. You know, skip every third night, skip every other for a while, then skip, you know, that type of
Yep,
thing.
exactly.
Okay. We got one more question here. I have an aunt diagnosed with Crohn's disease. What is that and how is it treated?
So Crohn's disease is a disorder that can affect patients from mouth to anus. It causes ulceration, inflammation, usually in a patchy fashion. In some individuals, it can affect small bowel only or only the colon. Most are within the colon and small bowel, that combination as well. It causes bloody diarrhea and abdominal pain. This is genetic. We know there are over 126 genes that can cause or are related to Crohn's disease.
Can it be without genetics? I mean, no one else had Crohn's disease in my family.
Yep, absolutely. It can be spontaneous as well. And yes, people need treatment for this long term. There can be a slightly higher risk of colon cancer if Crohn's is in the colon. And so people need to be on treatment lifelong for this.
So some people, I mean, it's that instead of ulcerative colitis that starts at the anus and kind of ascends, it can be spotty all over the place, including the small intestine and so on. It seems to be a tougher disease than ulcerative colitis, or would you say that it is?
I would agree with that statement, but I'm a physician too, so I think, well, if it's the colon is just the problem with ulcerative colitis, you can always cut it out. But unfortunately with Crohn's, if you cut out that segment of inflamed and scarred down lining and you put that piece back together, that disease will come right back at the exact same site. And over time, it can be a really horrible situation.
Tough deal.
Crohn's disease is one of those disorders that we are primary care physicians for those people, because you never cure them. But if you work with them, you can give them a good quality of life. But we as GI docs, we see a lot of patients. A lot of the patients I remember through the years were my Crohn's patients,
Yeah,
because
tough.
you lived with them, you suffered with them, and you worked through it. But most of them, you can get to where they have a good quality of life.
Have the biologics, you know, the new anti-rheumatology drugs, and been a godsend? I mean, they've saved.
They've been wonderful. I wonder
Absolutely.
how we did before we had them. I can remember when the first one, infliximab, came out, and everyone's like, "Oh my gosh, it's a miracle." Well, it works well, but these medicines have their own issues.
Yeah,
and so it's
and they're
all,
not cheap.
And they're not cheap.
Not at all.
But on the other hand, they have given people their lives back in many instances.
One of the best ways to watch for problems in the GI tract is to just go and look.
We usually start screening at 50 years old for people who don't have any symptoms and don't have any family history. Any family history of colon cancer, usually we recommend, if it's in a first-degree relative, we would recommend every 5 years. There are diagnostic colonoscopies as well as surveillance. Surveillance is when it's less than 5 years, but they've had something such as colon cancer or colon polyps that need to be monitored. And then a diagnostic colonoscopy is for people who have problems such as blood in their stools, black tarry stools, change in their bowel habits, abdominal pain, diverticulitis, something like that. That makes us that there's something specific that we're going in to look for. Abnormalities can be anything from masses to polyps, as well as diverticuli, hemorrhoids. I would say, even though they're really, really common, they are still an abnormality. There's also arteriovenous malformations, meaning abnormal connections between blood vessels. I've found actually quite a few lymphoid aggregates that look like polyps, but we still remove them anyway because we can't tell microscopic, we can't tell just by the naked eye necessarily. Any blood and stool should not be ignored because no matter what age you are, colon cancer can occur at any age. And I know of 30-some-year-olds who have died because they just thought it was hemorrhoids. I think the biggest deterrent for people not having colonoscopies is really the prep. Whenever I've talked to a person, they say, I just don't want to do that prep. The prep lasts a night, And yes, it is not fun, but the things that we can prevent from doing one prep is just, I mean, we can save lives doing colonoscopies. You could go through the prep, have a colonoscopy, take off polyps that could go into cancer, and that could prevent you from having to have a surgery, which would decrease your time at work, and you still need to go through a prep then.
Well, we had to wrestle that poor patient into agreeing to let us do her colonoscopy. Oh, it was Joni,
It was Joni.
my wife. Thank you, Joni, for willing to do that, and Dr. Wee, who was the surgeon. So the colonoscopy is an important issue, and I mean, I think we should touch base on colonoscopies. It is not that bad of a thing. Most of us get anesthesia, you don't remember any of it, it's just the prep. What's your take home on that?
Yeah, absolutely. I tell my patients the worst part will be the prep, and you will not remember a thing about the procedure itself. And so if you can make it through drinking a gallon or a half gallon, and now even a 2-cup prep, you know, it's such an important thing and a life-saving procedure as well.
This is Colorectal Cancer Awareness Month.
Oh, it is?
And the thing is, you know, everybody hears about colonoscopy and screening. This is the one cancer we can catch before it's cancer. I always tell patients with mammograms, you know, mammograms are very popular, they're very good, but they're designed to pick up early cancer. With colonoscopy, it's the polyp, the growth that can lead to cancer. Now, some of our viewers may say, not in my life am I going to get that done. An alternative, and you mentioned it on your quiz, is checking the stool for blood. We have a new test called a FIT. It's an immunochemical test. It's very specific. The issue is, though, if that stool test comes back positive, then you need the colonoscopy. But if it's negative, you're off the hook.
Yeah.
And at least you've been screened in some fashion. And we know that even that will save lives.
Yeah.
And in the state of South Dakota, 50% of people who need a colonoscopy over the age of 50 have not had a screening colonoscopy.
So
we are deficient in
We're
this.
shooting for 80% by
Yes.
2018.
But we have only 50% who've had their colonoscopies. So this is a call out for those of you who have not. Please do it. I had a dear friend who had a colonoscopy. I did it. Found a polyp, said, time to do another colonoscopy. Nah, I don't want to do that again. I don't want to do it. I don't want to do it. Oh, colon cancer spread. And it killed him. Please, you know, it killed my father. Get it done. We talked about Crohn's disease. Here is this about presbyesophagus. Older esophagus. Has nothing to do with the Presbyterian Church, right? A woman from, I don't know. A woman from Iowa has problems swallowing and was told that the opening of the stomach was fine, but that she has a spastic esophagus, manages it by being careful to not drink very cold beverages, and chewing slowly makes it easier. Are there other suggestions to treat presbyesophagus?
It's a difficult one to treat, but first of all, yeah, the extreme temperatures can cause spasm that could contribute. Now, in some individuals, if that esophagus is truly spasming, there are relaxants that you can give, not sedatives, but these are muscles that relax, these are medicines that relax smooth muscle, which is what the esophagus is made of. And in some individuals, that can be of benefit. Occasionally, passing a stretcher tube or a dilator across the esophagus might give benefit. But there is no
Real good answer.
easy
to
fix.
this.
And I think the viewer is doing the good thing, the best thing and the safest thing, and that is avoiding things that give her trouble, extreme temperature foods, and just drinking slowly and eating slowly. And really, that's as good as it gets.
What's the name of the medicine? Antispasmodics like Bentas and stuff like that? Or
Well, we have like calcium channel blockers.
And even nitrates can help.
and
Oh,
like good
nitroglycerin.
old-fashioned nitroglycerin
Yeah.
Yeah.
can be of benefit in small amount of people.
All right. My husband, 88 years of age, in 1996 had surgery for colon polyps but didn't have cancer. Since then, he's had colonoscopies periodically. He's 88 now. Do you think he still should have a colonoscopy?
That's a great question, and it's something that really we've looked at extensively, because you get to a point where you have to ask yourself, what is the risk of getting another cancer versus the risk of the procedure? Now, Christy said it's a very safe procedure, but as we get older,
It's not as safe.
things can happen.
Yeah.
And so the general guideline is up to age 85, and depending on the history and what's been happening, at that point you have to start having that conversation with the patient and say, here's the risks, here are the benefits. And at age 88, if he hadn't had many polyps in the previous 5 or 10 years, I would probably say
stop.
we're done.
Yeah.
Right.
And that's a hard thing to do, isn't it?
It
Because
really is.
doctors don't want their patients to
No.
get cancer, but it's the right thing to do.
And also, you have to think, if you find a cancer in an 88-year-old, will he or she be able to withstand surgery? So,
Yes.
you know, it's a very tough decision.
So in medicine, in our attempts to do well with people, sometimes we can harm. And I think this is an instance where at age 88, if it was me, I'd say we're done.
That's enough.
In the 80s, I had a patient. He wasn't an 80-year-old. He was in his 80s, but it was in 1980 something. And he was in my office, and his daughter was there, and I had done a hemoccult that was positive, so we ended up with a barium enema. We didn't have easy access to colonoscopies at the time, and I just did the barium enema, and there it was, an apple core lesion. In other words, it looked like, you know, the colon was coming along this way, and then it turned into an apple core. In other words, there was a stricture, so it looked like it was cancer.
Yes.
And it was. I'm sure it was. And it was right in the middle of the transverse colon. And I said, you're 88 years of age, and you're viable, and you're talking with me, and you make sense, and you have a normal life. I would recommend that we have it removed surgically. And he said, not in your lifetime. No way. I'm not going to have it done. And he died at 94 of a heart attack or heart failure or something. It wasn't the colon cancer, even that advanced. Because when you're 88, sometimes those cancers are also 88. Anyway, that was a story. Not to say that we shouldn't do colonoscopies and to resect those cancers, but when you get older, there's a time to...
There's a time to be done, and sometimes the treatment can be worse than the underlying problem.
That's right. Is there a difference between microscopic colitis and colitis? Christine?
Sure. So colitis just means inflammation of the lining of the colon. It can be due to infection. It can be due to inflammatory bowel disease like ulcerative colitis. So what is microscopic colitis? So probably about 20 years ago, we kind of figured out what microscopic colitis is. So these are individuals who struggle with diarrhea. And when you look at the lining of the colon, it's completely normal. But you take the biopsies and look underneath the microscope, and then you see inflammation in a few subsets. So yes, it is.
So what do you do for it?
So you can start with a few medications. The first and foremost is a kind of a low-dose steroid called budesonide or Entecort, and it will decrease those inflammatory cells. And it's amazing, the diarrhea really within 24, 48 hours stops.
So you treat it kind of like ulcerative colitis?
You can, yeah. You can use Pepto-Bismol. You could use other medications also to treat ulcerative colitis as well.
Pepto-Bismol. So what do you do with an infectious diarrhea? A person comes back from Mexico and they've got diarrhea from a Mexican experience versus a person who ate a raw hamburger because they really like raw hamburger and they like raw meat, rare meat, and they got infectious diarrhea versus a person who just came on a boat on a cruise ship and got diarrhea. Now those are three kinds of different. Could you explain those? We'll start with.
Well, there's different forms of infectious diarrhea. Some can be very serious, others not. The raw hamburger one is the one you worry about the most.
Yes.
There's an organism that can be transmitted with that's very serious called E. coli, and it's called the toxigenic version. These people are sick. They come in with bloody diarrhea, and you have to address that very quickly and give them supportive care. Not antibiotics, because sometimes that can make it worse, and then they can get complications such as renal failure and so forth. So that has to be diagnosed and supported quickly. Now, the traveler's diarrhea that you're talking about, very common when
The
you
Mexican,
go, the Mexican, and you
Montezuma's
get it through
revenge.
Montezuma's revenge, and that is not invasive, meaning the lining of the colon is not injured. You usually do not see blood.
Right.
You just see voluminous amounts of diarrhea. And that can be treated with a short course of antibiotics, and those patients usually do very well.
Okay, so that's great. The importance was that infectious raw hamburger thing. You need to, there's hamburger you just don't want
Well
to do.
done.
Yes. Okay, so we were running out of time, so we need to be quick on these next answers. New treatments for Crohn's disease in younger individuals, like 29.
So there are numerous different types of what are called biologic medications, and these are shots and infusions which target a specific part of the immune system. And now there are new cousins to this called integrin, anti-integrin factors. So lots and lots of new medications coming, and these are for patients with severe, moderate to severe Crohn's disease.
This one wants to have children.
Absolutely.
No problem.
And
No
yep,
problem.
it'll be fine.
Please talk about the specifics, prognosis, treatment options for people with esophageal varices and ascites.
Well, yeah, esophageal varices, what are they? They're enlarged veins. We all have small veins in our esophagus, and they don't give us any trouble. But when you have issues, most commonly with the liver, where blood that's shunted from the gut to the liver gets stiff and fibrotic. Cirrhosis is one of the commoner forms. That blood has to find an alternate route. And one of those routes are into the small veins which in the esophagus, which then become quite enlarged. The big risk there is if they bleed, if they rupture. Then you have an emergency. So we have treatments for these varices depending on their size. We have ways to prevent first-time bleeding, medications that can be of benefit in that. Also, we can go down, Christy and I, with a telescope, and we can put rubber bands on these veins in the lower part of the esophagus, which has also been shown to prevent rebleeding. So the answer is it depends on the cause. You have to determine the cause of these varices, number one. The prognosis, if you allow them to get to the point that they bleed, not so good. But if we're proactive and we get on top of this quickly and early, we can actually prevent bleeding and can have a much better prognosis.
But then cirrhosis is another story. We'll not go into that whole
And
story.
then you've got the whole liver issue, which you can't do anything about by banding the varices. You prevent the bleeding part.
Yeah, tough, tough. I have hoarseness in my voice box. It's not caused by acid reflux. What could cause this? So my guess is that oftentimes people have reflux. They don't think they have reflux, but the hoarseness is due to reflux. But it could be due to cancer. It could be due to smoking. It could be a lot of other
Postnasal
causes.
drip, yeah.
Postnasal drip. So but talk about acid reflux quickly as a cause of hoarseness.
So sure, acid reflux can come all the way up to the back of the throat, and then it's like a fine spray nozzle, and little drops of acid, and sometimes even non-acid will land on the vocal cords and attack. This is called LPR, laryngopharyngeal esophagitis. It's kind of a contentious area because we don't really know if all those patients who are diagnosed with LPR really have it or not. But simply have a trial of a proton pump inhibitor for
Like
8 weeks.
omeprazole, over the counter,
8 weeks, and
2 months.
yep,
Yes.
and see.
And the key is if you're going to do that, it has to be effective dosing. We too often give small doses, and to really determine if it's effective, it should be higher dose
So 40 milligrams of omeprazole?
for 2 to 3 months as a trial. And if they don't respond, chances are it's not. And by the way, endoscopy in those instances, not helpful. We just rarely will see esophageal injury in those
I agree.
patients.
Okay, but also the other causes of hoarseness can
Oh.
be cancer of this. of the
ENT
vocal-
Absolutely.
evaluation is critical.
Yes.
Ear,
Right,
nose,
ear-
and throat should take a look in there and make sure.
Absolutely.
Yeah.
Seems to have a leaky bowel from the morning and into the afternoon. Is there anything that can be done for this? Is there an explanation as to why this is occurring? So I'm probably rectal leaking.
That's
right?
what I'm thinking, yeah.
And I think that's one reason I don't recommend hemorrhoidal surgery, because once you start messing around with that kind of floppy, loose tissue that kind of falls in and prevents leakiness, you get scar tissue and then you don't have.
You lose tone. 10% of women who've delivered vaginally will end up with fecal incontinence, but we don't talk about that either. So it is a common thing. So you want to bulk up stools. You want to slow down, the stools. You also want to eat healthier foods. You don't want to be eating the greasy fast foods, fatty foods that can kind of zip right through you.
All right. And then if you need a Depends, then you need a Depends, no big deal. Don't feel that you have to stay at home. Get out and get among the people. We got to let those things, forget about them. Had a colonoscopy a year ago and they found 2 benign polyps, and I was told to come back in 5 years. Has a family history of colon cancer. Is wondering if 5 years is perhaps too long to wait for another screening.
No, it's not. We have the advantage of millions of colonoscopies to look at over a period of time to understand appropriate follow-up for these individuals. And these guidelines are pretty good, and they're based on a lot of evidence. So if someone has 2 or less polyps that are small, benign, then it's recommended that a 5-year follow-up. The family history of colon cancer, you'd never want to go longer than 5 years in those individuals. The other thing with family history it's important to understand is if you've had a first-degree relative that was diagnosed at age 75 or 80, we do not think that that increases your risk all that much. It's when your relative was diagnosed
At
under
40.
the age of 60. Those are the people that have the substantially increased risk, and you want to do what? But I think, Christy, in that situation,
years.
I would think 5
5
years would be
sounds-
reasonable.
Yeah, very appropriate.
But you could check the stool for blood once a year. And I would, my personal bias is I do that on everybody anyway. I do it the old-fashioned rectal exam, smear, Hemoccult. I know there's better and more sensitive tests, but boy, if they've got that, they get a colonoscopy from me. I don't know, I don't care. So if you see blood in your stool, you certainly want to get it done sooner.
Don't ignore it.
Don't ignore it.
Father and brother died from esophageal cancers, or something that female members of the family should be worried about.
Well, thankfully, women are not as high risk for esophageal cancer. Now, when an individual has 2 family members, you could say screening or looking inside the esophagus starting at around age 50 would be appropriate. But we see esophageal cancer, 60-year-old white men who smoke and drink. It's very rare for women to have esophageal cancer.
Wow.
Like Barrett's esophagus, I tell everyone, if you see a woman with Barrett's, I question the diagnosis. It's that rare.
So men are the ones. And one more reason not to smoke.
Absolutely.
Wow. I have had reflux, and I have been on a proton pump inhibitor for a long time. I recently read that proton pump inhibitors are related to risks of dementia and so on. You would say very minimal data.
And you have to realize that these are all just associations, and it's looking at millions of patients that have taken these drugs, and the numbers of people that they're making this association is very small. My advice is, if you need that medicine, take it. If you don't need it, you can try to get off it. Common sense approach.
Right. Had problems with diverticulitis. We got 30 seconds. Her stomach ruptured when she was younger. Had a total of 6 operations. Now has gastroparesis for about 4 years. Is very miserable. Discuss treatments of gastroparesis. What is it?
Gastroparesis, paralysis, slowing of the stomach, so slow stomach emptying. Treatment, diet, low fat, low fiber, small frequent meals. Liquids are better than solids. There are a few medications, but they also have side effects as well. Extreme cases, someone's losing weight, we can talk about feeding tubes as well.
Feeding tubes to keep them alive.
We
Rare
just don't
cases.
have real
Good
good,
answers
safe
for-
medicines for that. That is a tough one to deal with.
Tough one. And now for the winner of tonight's Prairie Doc quiz question. Pick the best answer. Screening for colorectal cancer, A, should begin at age 40. Yes? No, a little late. Unless there's family
Unless
history.
there's a family history.
B, at bare minimum, should involve checking the stool for blood yearly after the age of 50. Sounds pretty good,
Sounds
doesn't
pretty
it?
good to me.
C, involves having colonoscopy every 5 years after 55. Not soon enough. The best answer is B, checking the stool for blood yearly after age 50, or even better, get a full colonoscopy every 10 years after 50. It was Holly Rogers from Aberdeen who answered the question correctly. Thank you, Holly, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Good day, citizens. It is with regret that I inform you that the end is near for me. I'm old, I'm tired, I'm weak. But don't go thinking that you've won the war against the flu. Before I go to that big petri dish in the sky, I will find a suitable replacement. Be warned.
Last year, an elderly hospitalized patient with pneumonia was getting better after 3 days on powerful antibiotics when bloody diarrhea, cramping, and fever began, and his overall condition started to deteriorate. His stool test was positive for C. difficile, and he got better on a different type of antibiotic. This happened because too many of the good microscopic organisms, which usually colonize the intestinal tract, were destroyed by the antibiotics we gave him. This threw off an important balance of nature, and similar to a lawn with a patch of destroyed grass, the weeds invaded. It sounds like a sci-fi movie, but it's not. Scientists have discovered large numbers of micro-communities around and within every living plant and animal. Surprisingly, many of these invaders are necessary and helpful to the host, although some cause no benefit and some can be harmful. Microscopic organisms include bacteria, fungi, viruses, and parasites, and are called microbiota. Microbiome when referring to a genetic makeup of the tiny communities, or more commonly, the normal flora. Helpful non-human examples include bacteria fixing nitrogen on alfalfa, fertilizing plant and surrounding soil, or organisms living in the rumen of cattle, making grass turn into absorbable, nutritious food. The human microbiome has up to 10 times as many non-human cells as human and involve many organ systems, including mammary glands, skin cells, lungs, mouth, and eyes. The area where most normal flora reside, however, is within the gut or gastrointestinal tract. From the first minute after birth, the baby's gut is exposed to a microorganism-rich world. It starts with travel through the vaginal canal, followed by oral exposure to skin and milk flora while suckling at mama's breasts. Over the next year, baby's normal flora develops and helps the infant break down dietary fiber and fat while providing for a barrier to invasive organisms. Amazingly, foreign micro-communities also help synthesize vitamins, metabolize harmful toxins, reduce inflammation, enhance immune activity, and produce hormones. When human normal gut flora is depleted by well-intentioned antibiotics, an unintended consequence may be a catastrophic overgrowth of invasive bacteria. The most dangerous opportunistic infection is called Clostridium difficile, or C. diff. This type of invasive overgrowth was responsible for about 500,000 infections in 2011, with 29,000 of those dying within the first month. Take-home message: avoid antibiotics unless necessary. It's not nice to mess with normal flora. A big thank you to our guests, Dr. Christina Hill Jensen and Dr. Tim Ridgway. We truly appreciate it. Their willingness to travel to our studio and spend this time sharing their knowledge is genuinely appreciated. 182 new cases of flu reported this week, and over 400 people have been hospitalized with the flu in South Dakota this year. Don't delay. Get your flu vaccine now. It's not too late, and reduce your chances of catching the flu bug this season. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
We will do almost anything to relieve pain, but where does relief turn into addiction and cause additional health problems? Risks of daily opioids for pain. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera, is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota State Medical Association,
the Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen Asthma and Allergy,
Black Hills Medical Society,
Dakota Bank,
Orthopedic Institute,
the Physicians Care Sanford Clinic Community Service Committee,
Regional Health,
and Swiftel Communications.